Good afternoon and welcome to our second Virtual Health Academy. Today's virtual event is featuring Doctors Melissa McNeil, Tamar Krishnamurti, and Sonia Barrero from the Center for Women's Health Research and Innovation. Our experts will be sharing how they are elevating women's health by fostering innovation in research, education, and clinical practice. Now, to introduce our panel. Dr. Melissa McNeil, a professor of medicine, gynecology, obstetrics, and reproductive sciences at the University of Pittsburgh, is a founding member of Pitt's Academy of Master Educators and is now chair of the Educator Mentoring Task Force. Her interests include substance abuse and women's health, and she has developed third and fourth year multidisciplinary electives in both areas. Dr. McNeil serves as the Associate Chief of General Internal Medicine and Director of the Area of Concentration in Women's Health, a certificate program for medical students interested in obtaining additional training and expertise in women's health issues. She currently serves as the director of the Women's Health Residency track of the Internal Medicine Residency program and promotes a gender-specific approach to both primary care and subspecialty internal medicine training. Next, we have Dr. Sonia Barrero. Dr. Barrero is a tenured professor of medicine, clinical and translational science, and obstetrics, gynecology, and reproductive sciences at the University of Pittsburgh School of Medicine. She also directs the Center for Women's Health Research and Innovation and is associate director of the VA Center for Health Equity Research and Promotion. She's an internist with advanced training in women's health whose work strives to advance reproductive health equity. Her research has focused on understanding multi-level influences on contraceptive and pregnancy decision-making in marginalized populations in order to identify targets for social, clinical, and policy interventions that will decrease people's risk for undesired pregnancy and that will augment reproductive autonomy. Finally, we have Dr. Tamar Krishnamurti. Dr. Krishnamurti is an assistant professor of medicine in clinical and translational science at the University of Pittsburgh. She earned a Bachelor of Science in Biological Anthropology and a PhD in Behavioral Decision-Making Research from Carnegie Mellon University. Dr. Krishnamurti leads the behavioral health arm of the Center for Research on Behavioral Health, Media, and Technology, and is co-founder of the FemTech Collaborative, housed within the Center for Women's Health Research and Innovation. Her research interests include risk perception and communication, medical decision-making, M-Health, and the design of decision support tools and behavioral interventions. She recently received the SNR Foundation's Kuno Award for Applied Science for Social Good and spoke about her approach to equity in digital health at the first Nobel Prize Summit. I'd now like to pass the presentation to our first panelist, Dr. Melissa McNeil.
Good afternoon, everyone, and thank you for that lovely introduction. It is my pleasure today to talk to you about, in broad strokes, about the concept of what women's health is. What is it? How do you create it? So I want to ask you if this sounds familiar to you. We have Aisha. She's a 35-year-old woman. She presents to her internist with worsening migraines. They occur around the time of her menstrual cycle. Her internist thinks they might be menstrual migraines and sends her to a neurologist. The neurologist agrees and thinks about starting oral contraceptives, but the neurologist doesn't prescribe these. So now she goes to see her gynecologist. Wouldn't this be better? Contrast that interaction with the healthcare system to this. She goes to see her women's health internist with complaints of menstrual migraines. The internist is well-trained in women's health. She's comfortable in making this diagnosis and in prescribing oral contraceptives. The patient leaves that one visit with the appropriate medication in hand. So the challenges we face in caring for women are many. It begins with the fact that the care we provide women is fragmented. We silo reproductive health care issues from the overall health care of women. Women receive their gynecologic care, including hormone therapy, and that includes contraceptive care and postmenopausal hormones from gynecologists, and the remainder of their care from internal medicine. But as was just demonstrated for poor Aisha, separating hormones from the brain, the heart, the bones, and the breast is fragmented and inconvenient and often leaves gaps in care. Healthcare for women has often been described as a patchwork quilt. So what is women's health? Well, we think of women's health broadly in three different sectors. The first are diseases unique to women, and we think about these a lot. These are pretty obvious. Contraception, menopause, reproductive tract cancers, those are obvious. Things that are perhaps a little less obvious, but will still ring true, I think, are the diseases more common in women. Things like thyroid disease. Thyroid disease is unique in women because certainly if you get pregnant or if you're on hormone therapy, we need to adjust your thyroid medication. So it's a little bit different in women. Osteoporosis and incontinence, certainly illnesses that are way more common in women and whose management is actually a little different based on the gender. And then finally, the thing I think that we do the least well in addressing are the diseases that present differently in women. The classic example is chest pain syndromes. We know that our women who present with chest pain are much less likely to be taken seriously. Their syndromes are different and not the classic syndrome that a man presents with, and they are often overlooked. They get referred for cath less, they get referred for interventional cardiology less. Things like depression and anxiety, again, present differently in women, are more common in women, and are often undertreated and overlooked. And substance abuse falls into the same category. So what are the challenges then? The challenges that we face is that the education in the issues that I just talked about are often segregated by specialty. Internal medicine versus gynecology. Internal medicine specialists focus on cardiac disease risk assessment and treatment, bone health, screening, and the prevention of breast cancer. Gynecologists are experts in the treatment of reproductive health, managing the symptoms of menopause, the dosing and titration of hormone therapy. And certainly, obviously, things that are in the domain, that belong in the domain of gynecologists solely, like pregnancy, delivery, managing gynecologic cancers. But to be effective in the care of women, we need to bridge these silos. Hence the need to train providers and to develop clinical programs that develop gender-specific primary care. So the goal in the programs that I have built and the educational initiatives that I have put forward is to develop a one-stop shopping model for women's health to provide gender-focused primary care and specialty care. So how do we train these providers? Well, there are really two approaches. We could either enhance the medical training of our gynecologists, or we could increase the women's health training and expertise of our internal medicine residents and fellows. We're in internal medicine, so our approach has been actually threefold. The first is just to increase the women's health content in our clinical didactics and experiences for our internal medicine residents across the board. Everyone needs to know more about women's health. 50% of the patients that come to a primary care practice are women. We then went on to develop a concentrated track in the internal medicine residency for residents interested in focusing on women's health. And following that, we developed a post-residency fellowship for faculty development to help faculty who are interested in enhancing their women's health knowledge even more, but also in becoming academic physicians who either teach women's health or research women's health. So the first step was to identify the content areas and where we thought they belong. To the generalist, to the internal medicine provider who needs to be able to provide outstanding care for women, or to the women's health content expert. For everyone, contraceptive counseling, incontinence, osteoporosis, certainly thinking about chest pain, screening for breast cancer, intimate partner violence, and sexual history. All of these things are critical to providing outstanding care for women and often get overlooked in the internal medicine training. For folks who are interested in going farther, our internal medicine residents and fellows, we actually spend a lot of our time talking about prescribing hormonal contraception, actually teaching them how to insert intrauterine devices. We do a lot with menopause. We talk about the counseling and the prescribing of hormone therapy, the primary prevention of breast cancer, not just screening for it, but identifying who's at high risk and who might benefit from pharmacotherapy to prevent their breast cancer. We manage abnormal uterine bleeding, and in particular, we focus on the need, the necessity really, to incorporate a reproductive history into the cardiovascular assessment of women, because we know that things that internists classically don't ask about, like preeclampsia, change the risk of whether or not you're likely to develop cardiovascular disease. So in the categorical residency, what were our goals? We wanted to establish didactic curricular goals and to assure adequate exposure to women's health clinical experience. We developed dedicated women's health experience with rotations in specialty clinic, such as high-risk breast clinic, urogynecology clinic. We put women's health learning opportunities into already existing teaching venues, our conferences such as Morning Report, when we round on the wards, and when we, as faculty, serve as the preceptors for our resident clinic. Now, obviously, one of the things that this requires is faculty with expertise in these issues, and we'll talk a little bit about how we develop those. In the internal medicine residency training, we emphasize a number of things. We ensure first that a gynae history is taken. We emphasize the need for intimate partner violence screening and a sexual trauma history. We emphasize the need for a pelvic exam and all abdominal pain, cancers of unknown origin. And we emphasize gender issues, clotting and hormones, contraception, reproductive aging. We talk with our women who are in their 30s about their child rear, their plans to have children. And then, as I talked about already, the gender-specific risk factors for cardiovascular disease and eating disorders. I'll give you one quick example. I was taking a clinical case conference. It was a young 18-year-old woman who presented with total body clotting. And we had a lovely academic discussion about the etiology of the clotting, what the underlying hematologic problem was. We figured it all out, and the treatment was to send her home on anticoagulation. The group was done, kind of, clapping their hands. Everybody was finished. I said, no. What are you going to tell this 18-year-old woman now that you're sending her home on anticoagulation? In particular, warfarin, which is teratogenic. And, the group kind of looked at me a little bit clueless, but fortunately there were women's health residents in the room, and they actually knew what I was talking about. The first point is she's going to have really heavy menses. And the second is contraception is going to be tricky in her. She's already got a history of clots. She can't have oral contraceptives. But good news, this is where an IUD manages everything. Decreases her bleeding, gives her outstanding contraception at no risk. And that's what women's health is all about. And that was a women's health educational moment for categorical residents, our routine residents in the middle of what they were already doing. So the ingredients for success for developing this is a critical mass of faculty willing and able. And as a result, we've developed a section of women's health, which is about 20 strong in the Division of General Internal Medicine. We agree anytime, any place to teach, but we want to pick our topic. And frankly, we are as good as anybody else at internal medicine, as well as hormone therapy, because that establishes our credibility that women's health is important. The residency training goes beyond. Our track in the women's health residency, we offer a different focus. We have unique clinical experiences with dedicated women's health faculty. Our guys don't just talk the talk, they walk the walk. We have a dedicated weekly seminar series where we highlight topics that are important to the care of women that are not traditionally covered in internal medicine. And we have unique elective experiences that they get, which include reproductive gynecology, adolescent medicine, urogynecology, student health, the breast center, the women's heart clinic, and the eating disorder program, among others. They get careful mentoring, hands-on learning, and they have the opportunity to work with the internal medicine women's health faculty in their own primary care practices who provide gender-specific primary care. And so what we've done in this setting is expand the traditional domain of internal medicine. There are pros and cons to having a track in a women's health residency. Ideally, we would like everyone to receive the same women's health education as women's health residents, but the resources and competing demands limit our ability to do that. But what we have found is the presence of a strong women's health residency generates a clinical and critical mass of trainees guaranteed to ask in any session, what did the pelvic show? One of my most favorite moments was one of my women's health residents came and found me and said, Dr. McNeil, I did a pelvic exam in the ICU, blew their minds, and I was so proud. So what we see is our women's health residents actually really infiltrate into the categorical residency. Components of success, you have to have buy-in. Buy-in from leadership, our program director from the residency, the division chief of general medicine, who's allowed us to build our section, the chair of our department, and the dean. And actually, I would be remiss to say that we also have buy-in from the Department of Obstetrics and Gynecology. We partner very well with them. We have our OBGYN colleagues in our clinics for consultative work. We've built a section of women's health. We have dedicated faculty within general medicine. We have partners in our medical subspecialties, oncology, cardiology, endocrine, GI, and apparently cardiology twice. And in fact, it's interesting, the person who directs our women's heart program right now is a graduate of our women's health residency track. And then obviously we identify partners in other departments, OBGYN, psychiatry, adolescent medicine, to name a few. So summary, women's health in the residency level needs to be broad-based and occur along a continuum of training. You have to have a strong, dedicated, credible faculty. You have to look for opportunities to incorporate training and experiences into already existing lectures and clinical experience. Good news, 50% of the folks that we see are women. So as long as you have faculty that can teach, you're in good shape. We don't need to go out and find women. We expand to specialized electives as resources will allow. And I will tell you, if you build it, they will come. We have graduated well over 100 residents from this track, and they are in just about every specialty you can name. Which brings me to Women's Health Fellowships. Our Women's Health Fellowship was initiated in 1994. This is an opportunity for specialized training in women's health. The goal here is to develop physicians with strong clinical training in women's health who are interested in careers with clinical medicine and then some, either as clinician educators or as clinician researchers. It's a little bit interesting that the funding comes from the Department of Veterans Affairs and recognition that the VA had way back in the 90s of the increasing number of women who were separating from the military and not receiving good care. They fund 2 fellows each year for a 2-year fellowship with the opportunity for a 3rd year of funding. Again, the components of success, dedicated funding. It's included within a broader fellowship structure. There is an extremely strong clinical, educational, and research environment. There are many mentors for either the educational initiatives or the research initiatives, and we have a critical mass of learners and faculty at all levels. There is seed money for our scholars for research, either in educational initiatives or more traditional research endeavors. There's a strong clinical environment with a comprehensive women's health program at both UPMC and the VA Pittsburgh. There are unique educational opportunities for our fellows. They finish either a master's in clinical science or a master's in medical education. And through each of those programs, they maintain a women's health content focus. There are multiple research opportunities, not the least of which is the Center for Women's Health Research and Innovation. 25% of their time is clinical. The remainder of their time, they're pursuing their master's degree with training either in education or research. Everyone has a requirement for scholarship because the goal is to train the trainers, the next generation of women's health physicians who will go forward and innovate. Some of the initiatives out of our fellows, a curriculum in managing gender harassment in the clinical setting, a curriculum in transgender medicine, the evaluation and development of a substance abuse program for women alone. Our research initiatives, contraceptive decision-making and equity, led by Dr. Barrera, who is a graduate of our fellowship, so we'll take full credit for Sonia. We've looked at the quality of life in menopause. We've looked at menopause and sexual health and the markers of that. So my takeaway messages are that the care for women should be comprehensive and integrated. This avoids gaps in the care and inconvenience for our women patients about the need to see multiple providers that are easily managed by one well-trained clinician. Training physicians as educators or researchers with women's health expertise provides that critical mass for high-quality clinical care and academic pursuits and advances the field with educational and research innovations. And with that framing of our educational initiatives, I'd like to turn the program next to Dr. Sonia Barrero, a graduate of both our residency track and our fellowship, and have her tell you a little bit about the fabulous work that she's been doing.
Okay, thank you so much for that, Dr. McNeil. And yes, I'm a proud product of several of your training programs. So I'm Sonia Barrero. I'm the director of the Center for Women's Health Research and Innovation. And I'm going to be talking a little bit today about what we do here. So our mission at Query is to improve women's health and also gender equitable health by fostering innovation in research, education, clinical practice, and policy. We center our activities on a number of things. So first and foremost, we conduct innovative multidisciplinary research. And in this research, we pay particular attention to socially and economically marginalized populations, as well as those that are medically complex, and sometimes the intersection of all of those. We foster partnerships with community stakeholders, both to inform our research agenda, but also to help translate the research into meaningful practice and policy interventions. And then finally, we spend a great deal of time mentoring future generations of scholars in women's health and gender-related health. Currently, we comprise about 30 affiliated faculty, and these faculty come from multiple departments and schools across the university. Our faculty have expertise in women's and gender-related health across the lifespan, from adolescence to midlife and aging. And our specific areas of focus, and in fact, we have several national experts in gender-based violence, family planning, including contraception and abortion care, perinatal and pregnancy care, and the intersection of gender and chronic medical and mental illness, including substance use disorders. So we have a number of fantastic faculty, and I just want to highlight a couple of very high impact research that I think have either informed policy or have informed paradigm shifts in clinical practice. So the first one is actually a study that was conducted by one of our trainees, Colleen Judge Golden, who will be graduating with her MD next week, but worked with us on her PhD. And this study is a cost analysis in which Dr. Judge Golden modeled both the health and cost implications to the VA healthcare system if they were to adopt an evidence-based strategy of offering 12 months of contraceptive dispensing at a single fill. And she found that in addition to a significant number of undesired pregnancies averted, this is a cost economically sustainable or feasible model for the VA healthcare system. So in addition to getting a lot of media attention for this work, it in fact led to proposed legislation by Representative Lauren Underwood last summer to enact legislation to make this a policy change within VA. This next work is by Dr. Holly Thomas. Dr. Thomas is interested in understanding the psychosocial factors that contribute to sexual dysfunction in midlife and older women, and using this understanding to develop effective behavioral health interventions that go beyond traditional paradigms that really have focused solely on biology when managing sexual health issues in midlife women. This work is by Dr. Miret Birutalabi, who's one of our adult rheumatologists. Her work has illuminated that current clinical approaches largely fail to proactively identify and support people's individualized reproductive and pregnancy preferences among those with serious chronic medical illnesses. And instead, the predominant approach to pregnancy, especially in subspecialty medicine, but even perhaps in primary care, can be disease-centered rather than patient-centered. And so to better meet the individual needs and preferences of people who are interested in becoming pregnant and have chronic medical conditions, our research team has really been advocating a paradigm shift in subspecialty care that honors individuals' reproductive autonomy. We propose that increased attention to patients' pregnancy preferences and integration of those preferences into treatment plans may actually help to improve pregnancy outcomes among people with chronic medical illnesses. So Dr. Birutalabi has been working with a number of subspecialists across various divisions in cardiology, neurology, hematology, oncology, and pulmonary medicine to identify and address the deficiencies in sexual and reproductive health care and provide whole person care. Very similar to what Dr. McNeil actually proposed in her opening slides. Many of these patients who go to see their subspecialists often view their subspecialist as their de facto primary care doctor and expect to receive sexual and reproductive health care from them. This work is by Dr. Marian Jarlensky, who is actually the Associate Director for Query. And her research program seeks to advance knowledge about the causes of and interventions to improve health and well-being among people with substance use disorders. Her work draws from a reproductive autonomy framework, much like much of the work of our Query faculty members. And it focuses on pregnant people who face multiple sources of marginalization, such as intergenerational poverty and stigmatization. And then this final piece of work that I would like to highlight is one of mine. This is a study that we published a number of years ago, but continues to inform ongoing conversations about how to transform Medicaid policies around sterilization. So female sterilization is a commonly used method of contraception in the US, especially among low-income populations. And Medicaid is the payer for over 40% of all sterilization procedures. Medicaid consent guidelines and recommendations currently require that women requesting a federally, or actually people requesting a federally funded sterilization procedure complete a standardized consent form at least 30 days prior to a desired procedure. So this creates basically a mandatory 30-day waiting period. And while the intention of this process was to protect individuals from coercive sterilization practices, our research has identified that it creates significant barriers for low-income people seeking sterilization, often leading to undesired sterilization, or often leading to unfulfilled sterilization requests and undesired pregnancies that can lead to both abortions and undesired or unintended births. So this work has really led to ongoing national dialogue about how to best transform Medicaid sterilization policy to meet the dual needs of protecting vulnerable populations while also eliminating access barriers to a desired sterilization procedure. So in addition to, lots and lots of great high impact publications, our faculty are often in the news. And I think there is a breadth of the platforms on which their work has been featured, anything from Rolling Stone to Good Morning America to The Atlantic. And I think this breadth of media exposure really illustrates how relevant the research that our faculty are doing in terms of impacting people's lives and reflecting current realities. I mentioned before that we foster relationships with community partners. And again, this is really to help inform our research agenda, but also to help ensure that as we continue to promote person-centered approaches in clinical care, that we do so with attention to the intersecting systems of oppression and structural injustices that really impact people's lives. So one of the things that Query has launched several years ago is the Reproductive Bridges Coalition. We really leveraged the community connections we have and pulled together a coalition of stakeholders in women's health and reproductive health across the region to really not only ensure but expand access to high quality comprehensive reproductive health care for all individuals in Western Pennsylvania. And I just want to highlight a couple of the wins that we've had over the years. So this picture is from our inaugural State of the Science symposium. We brought together key health decision makers in the region, legislators, insurers, healthcare systems, and foundation folks to really talk about the importance of ensuring access to both contraception and abortion. And we then sort of entertained dialogue about what were the barriers at these various sectors in moving that mission forward. In the second year, we put on what we called a day of learning at the Carnegie Science Center. And here we provided free hands-on education in the provision of long-acting reversible contraception, IUDs and implants. And we had about 100 people come from across the region, as far as Ohio, to participate in this session. Building on some of the work that we had been doing in long-acting reversible contraception, we conducted some research with providers in our region to understand what were the barriers to providing IUDs and implants in adherence with best practices. And based on that research, we created this infographic, which we distributed to many clinical practices to help with not only enhanced provision, but ensuring adherence to some of the best practices that we identified were deficient. Last year, Dr. Jarlensky and I engaged in some cost analyses in partnership with the Pennsylvania Medicaid office. And we provided some of the cost estimates, again, for offering the option of 12-month contraceptive dispensing at a single fill. This is an evidence-based strategy that's been adopted by several states. And we looked at what the cost implications would be to the Medicaid program here in Pennsylvania. And based on our work, they issued a memorandum, in fact, recommending that all of the managed care organizations under Medicaid start to provide 12-month dispensing. So we were pretty excited about that. And then most recently, we've been working with some of our state representatives around expanding confidential care to adolescents. This is a proposed legislation to suppress what are called explanation of benefits for dependents who are seeking sexual and reproductive health care, such that their guardians or parents are not receiving notification from insurers that they in fact received sexual and reproductive health care. So this is, I believe, on the docket for next week. So just a snapshot of some of the things that the Reproductive Bridges Coalition has accomplished in the last couple of years that we are particularly proud of. So in addition to the Reproductive Bridges Coalition, we have another initiative within Query, which is the Femtech Collaborative. And I'm going to turn it over to my colleague and friend, Dr. Tamar Krishnamurthy, to talk more about this.
Thank you, Dr. Barrero. I'm so happy to be here today to be able to speak a little bit more about my work in building mobile health tools for pregnant people as part of a larger collaborative housed here in the university, as Dr. Barrero mentioned, the Femtech Collaborative. And here we all are. This is the core faculty of our multi-institutional, multidisciplinary team of researchers. And together we have a number of tools that have been built to address sexual and reproductive health decisions. Originally, we were working somewhat independently in our own specializations, but quickly came together when we realized that we had a common problem that we were trying to solve in the space of femtech. So for some of you, femtech may not be a familiar term. Femtech refers to digital tools or services that are designed to specifically address women's health needs. Outside the scope of the university, femtech is now a booming industry. And you can see this on the graphic that just a few of the femtech tools that are now commercially available. But what's a little surprising is that tools to address women's health needs have until recently been considered niche. This is surprising because most obviously, female bodies constitute half the population, but also women use the healthcare system more than men. They spend more on healthcare. They also tend to live longer, but as Dr. McNeil discussed earlier, they have increased risk of multiple chronic illnesses, and they're usually playing the predominant role as caregivers in their homes and communities. In fact, they make about 90% of the healthcare decisions for a family. So women's health is clearly an important focus of tech development. But unfortunately, much of the available tech developed for women is developed without taking into account the needs and perspectives of those people that the tools are actually designed for. So as a group, our Femtech Collaborative came together to solve the problem identified here, that current healthcare delivery models fail to proactively identify people's reproductive needs or support their autonomy in their own healthcare decision-making, and are thus not poised to address preventable adverse outcomes in a patient-centered way. So our Femtech Collaborative was founded on the desire to make women's health technology more patient-centered, better at facilitating patient and provider communication, and that could help women to navigate difficult health decisions. So how do we do that? Well, we build tools using a process that is first and foremost based in scientific evidence. We work with the patient populations that our tools are designed for right from the start. And this goes beyond just things like user testing. Patients' values, desires, and autonomy are at the heart of the design and shape the evolution of what we're building. Tools that aren't designed carefully can exacerbate inequities through limiting access or prioritizing the needs of people with greater social privilege. And we often see that in the commercial world where the revenue of many tools is dependent on marketing. Our team is dedicated to ensuring that any digital tool is aligned with a mission of advancing equity. And so now I'd like to showcase some of these exciting tools that have been developed as part of our collaborative group to address different time points on the reproductive journey. MyPath, which is a patient-facing web-based tool, was created by Dr. Lisa Caligari to facilitate shared decision-making conversations around either preparing for pregnancy or contraceptive method selection. The idea is that the research has identified that having conversations about people's pregnancy preferences, especially when they have potentially stigmatized conditions, things like substance use disorders or chronic health conditions, can make it complicated, and that can be challenging for necessary disclosure to a provider. So tools like MyPath can really offer support that's needed to help people making their own informed reproductive choices. My Voice uses the same approach as MyPath, but has been carefully tailored by Doctors Tracy Kazmarsky and Miret Barutalabi to vulnerable populations with specific medical conditions. Here you can see a version of My Voice that has been specifically developed for those with cystic fibrosis by Dr. Kazmarsky. Dr. Miret Barutalabi has been working to offer a different tailored tool for women with rheumatic disease. The MyHealthy Pregnancy platform is what I'll be talking about more in depth in a minute. On the left is a patient-facing smartphone app. It collects information about risk factors for earlier risk identification than is possible through routine prenatal care. It offers education and a speedier connection to appropriate resources to decrease the risk of adverse pregnancy outcomes. On the right is an EHR embedded provider portal so that physicians can see risks that are identified through that app in real time and respond. And then for people who are reaching the end of their reproductive journey and are considering sterilization, Dr. Sonia Barrero has built MyDecision, which is a tool to support informed and value concordant choices. And so you can see that as a group, our tools really span a woman's reproductive journey. And now I'd like to highlight the kinds of results that we're beginning to see with just one of those tools, the MyHealthy Pregnancy platform, which is now available through spin-out company Naima Health. So to start, I wanted to give a little backstory on what motivated the development of MyHealthy Pregnancy. In the United States, our maternal and infant health statistics are shockingly poor. We have the highest maternal mortality rate in the developed world, with the majority of maternal deaths being preventable. And preterm birth, which is birth occurring prior to 37 weeks of gestation, is the leading cause of infant morbidity and mortality. And so addressing potential adverse events during pregnancy is critical to national health. High-risk pregnancies are complicated to predict, however. Many risk factors are intersectional, and often these factors, things like depression or violence experienced during pregnancy, aren't detected soon enough for a timely intervention. And so we built MyHealthy Pregnancy using an approach that combines machine learning for risk prediction and behavioral science to support appropriate disclosure, with the goal of supporting earlier and better risk identification and risk reduction behaviors during pregnancy. Right now, we're wrapping up a beta test of our tool in the UPMC system. We've had over 4,500 pregnant people enroll and use the app, and it gets prescribed to a patient at their first prenatal visit. In early data analysis, what we're seeing is that the use of our tool is highest among those with higher baseline risk factors and for risk factors that emerge during pregnancy. And so what that means is that people are making the choice to use this according to their needs. Since rolling out our tool, we've been able to set up a care team who can be responsive to risks that are identified in the app. So if, for example, a patient reports symptoms of depression, an alert can be sent to the care team, who will then reach out and provide patients with resources and referrals in addition to those resources provided in the app. And that gives patients options about what care they receive in a more responsive way. And so going through some quick results so far, for almost 90% of the cases of depression identified through MyHealthy Pregnancy, we've been able to connect people with some form of care, whether it's cognitive behavioral therapy, resources they can use from home, or social services to address specific needs that were negatively affecting their mental health. For preeclampsia, which Dr. McNeil had discussed previously, and which is a leading cause of maternal morbidity and mortality, we were able to successfully administer risk assessments to almost 100% of our app users. And we found that more than half of those with preeclampsia risk factors reported not receiving prophylactic treatment from their providers. presenting an opportunity for us to address this critical risk factor through the app. Disclosure for intimate partner violence is an option that's offered to our app users. And what we're seeing is that disclosure rates for this risk are higher in the app than in-person care, offering an opportunity to provide more resources to those facing this risk, sometimes in a more discreet way. And then lastly, during the COVID-19 pandemic, we've been able to pivot some of our services and triage pregnant patients using our app to minimize their chances of exposure by coming into the healthcare system unnecessarily, as well as an ability to kind of offer feedback based on information shared with us through the app on what appropriate risk reduction actions are. And so what you can see on the right there is just some quotes of COVID risk perceptions that were shared with us through the app and that we were able to address with education. So this was just a short introduction to the type of work our Femtech Collaborative is doing. And our vision moving forward is really to become a national hub for the development and evaluation of digital tools to optimize reproductive health outcomes, and really to do that within health equity framework. And that concludes my presentation. Thank you very much.
Thank you to our panelists for sharing your time, passion, and work with us today. And thank you all for attending our second Virtual Health Academy. We hope you found today's program informational and inspiring. We are proud to have innovators like Drs. Barrero, Krishnamurti, and McNeil paving the way in academic and clinical medicine. If you have questions, please do not hesitate to reach out to Alex Rigby at amr276@pitt.edu. Our health academies are held on a quarterly basis to provide a unique platform to showcase groundbreaking research and advancements in the health sciences, and we hope to see you in the fall.